Okay, so our next topic is going to be joints. And so we just finished up bones and skeletal tissue. And so the way that bones come together, because we've talked about them kind of independently, is bones come together and form joints. And we see this throughout the body. And there's different types of joints, and we're going to get into that. Um, I also want to mention this term. This is articulations. Okay, and this is basically like the fancy word for joints. Okay, so you're going to see both of these. And so the way that we would even use this is to say, okay, this bone articulates with another bone to form a particular joint. So you're gonna end up seeing this word throughout some of the material that we talk about. So when we look at joints, we can classify joints in two different ways. So one is going to be structurally based on structure. So this is basically looking at what material forms the joint and whether the joint has a joint cavity, which is going to be kind of a space, like if we had the end of one bone and then we had the beginning of another bone, do we have kind of this space here in between the two bones? So is there a joint cavity? That would be kind of in between those two. And what type of joint or what type of material actually forms the joint? Okay, and we've got three different options there. We've got fibrous joints, cartilaginous joints, and synovial joints. Our other way to classify joints is based on function. And so this classification is based on how much movement is available at that joint. So we've got three different categories here. We've got synarthrotic joints or synarthrosis, which are going to have basically no movement. We've got amphiarthrotic joints that are going to have a little bit of movement, so little movement. And then we've got diarthrotic joints, which are going to have free movement, so lots and lots of movement. So if you look at the body, most joints are diarthrotic, most joints are freely movable, and most joints are synovial. So here's your two kind of highlights, okay? Okay, so let's go through functional classification first. So here's our synarthrotic joints. Again, these are immovable joints. And some examples of synarthrotic joints are the sutures in the skull. So these suture lines here that are created between skull bones, those are actually joints, and they don't move. And also your teeth in your maxilla at the top and your mandible at the bottom. So these are technically joints, but they don't actually move. So in terms of complementarity, the question that we would ask here is, why does it make sense sometimes to have joints that don't move? And it does make sense. The skull wouldn't be nearly as protective of our brain if these joints, formed here were freely movable. It wouldn't offer the protection that it did, and then our teeth would be falling out of our skull all the time. So it does make sense in some cases to have joints that don't move. Our second functional classification is Amphiarthrosis, and these joints are slightly movable. So some examples of amphiarthrotic joints would be the joints formed between the vertebral bodies of the spine, the joints formed between the ribs and the sternum, and then the joint formed at the pubic symphysis. So if you take a look at all of these are basically joints formed of the axial skeleton, right? So we have a little bit of movement, but really the axial skeleton, if you think about when we talked about axial versus appendicular, it was more for stability rather than mobility. So axial skeleton's role was more stability based. And so that's what we see there. We see a little bit of movement, but actually providing a little more stability than mobility. And then we have our freely movable joints. So these are going to be diarthrosis joints. They can move in all these different planes of motion, And examples of diarthrotic joints are going to be basically any joint in your upper and lower extremities, meaning arms and legs, also meaning our appendicular skeleton, right? Because if you think back, the function of our appendicular skeleton was to move, was to we always kind of say manipulate objects. You know, you need to be able to pick up your coffee cup. You need to be able to walk into the kitchen, you know, that sort of thing. So if you look at the joints here, shoulder, hip, elbow, knee, wrist, ankle, fingers and toes, all of those are going to be freely movable joints. And so we do have this relationship here where stability and mobility are inversely proportional. And this is a picture of a dislocated shoulder. Okay, so one of the things that we see is that if we have a joint that has decreased stability, its mobility is going to be increased. Okay, and that's what we see with the shoulder. The shoulder is a diarthrotic synovial joint. It has increased mobility. It has tremendous mobility. Think of all the different ways you can move your shoulder, but as a result, as a trade-off, it's got decreased stability. And so there are cases where this type of thing happens, right? On the flip side, if we have a joint that has decreased mobility, it's going to have increased stability. So think about your spine, right? Spinal joints, joints between vertebral bodies, are going to be amphiarthrotic. They don't move as much, but as a result, they provide us with more stability. And that makes sense because all of our extremities, our upper and lower extremities, attach and form, you know, our vertebral column kind of forms a framework for our other joints to attach to. So it needs to be a little more stable in order to provide that. And then we can look at our structural classification. So this is classification based on structure, which is basically what is the joint made from. Okay, what type of material? And so what we see here is, let's redo that one. Yeah, what is a joint made from? And so with fibrous joints, what we see is that the bones are connected by connective tissue collagen fibers. There's no joint cavity, so there's no space between bones. Okay, and most of these guys are going to be immovable. So for the most part, they're going to be synarthrotic. And some of them might be slightly movable. So they would be amphiarthrotic. So typically what you see with joints is that you're going to describe it with two terms, right? So each joint is going to have both a structural and a functional descriptor. So maybe shoulder joint, for example, would be synovial diarthrotic. Synovial tells us the structural type of joint, and diarthrotic tells us the functional. Okay, so under fibrous joints, we've got three types of fibrous joints. We've got sutures, syndesmoses, and gomphoses. And so what we see there, sutures are going to be just like the sutures in the skull. So that's going to be a particular type of fibrous joint. So we've got these little tiny fibrous, connective tissue fibers that are going to connect, and they're very short, and the bones are right up against one another. So there's really no movement that's happening at those joints. A syndesmosis is going to be basically the same setup, but we've got collagen fibers that are a little bit longer that are connecting the two joints with each other. So we can have a slight bit of movement, or what we would call slight give, So in this example, we see this joint at your ankle. And so when you move your foot, up towards your head, that joint right there is going to give just a little bit to allow some space for your ankle bones to move into. So slight give at that joint. And then a gomphosis, which is basically your tooth and your tooth and socket type of joint. So we see this with your mandible and your maxilla. So no movement there. Shouldn't be any movement at the teeth. Okay, second type of structural classification is going to be cartilaginous joints. And as you would imagine, these are going to be joints that are connected by cartilage, right? And so what we see are two types of cartilage. We know that there's three types of cartilage, right? We know we've got hyaline cartilage, we've got fibrocartilage, and can you remember the third type of cartilage? Right? Third type of cartilage was elastic cartilage. But elastic cartilage doesn't make great joints. So we only see elastic cartilage in the ear and the epiglottis, right? Those were the two places that we see it. But we don't have elastic cartilage that makes joints. So we're only left with two. So we have hyaline and we have fibrocartilage. Cartilaginous joints also don't have a joint cavity. We see slight to no movement with them functionally. And we have two types of cartilaginous joints. So these guys are either going to be synchondroses, which specifically means that they are attached by hyaline cartilage, or they're going to be symphyses, which means that they are specifically attached by fibrocartilage. So the type of cartilage determines what specific type of cartilaginous joint it is. So if we look at that, here's an example of a synchondrosis, and we know that that means these are joints attached by hyaline cartilage. Examples of this would be the epiphyseal plate, which we know we've got a line of hyaline cartilage separating bone from bone. And so that is technically a joint until it closes, at which point it's not a joint anymore. And then the joint formed by the first rib as it comes around and attaches to the sternum. Okay, so both of these joints are immovable joints. This should also be an immovable joint. But these are joints attached by hyaline cartilage. The second type is going to be a symphysis. Okay, and so these are specifically going to be joints that are attached by fibrocartilage. So these are going to be the joints formed between adjacent vertebral bodies, separated by the intervertebral disc. And we know that that intervertebral disc is formed by fibrocartilage. And so that's going to be a symphysis. We also have another example of a symphysis, the pubic symphysis. The two halves of the pelvis attach anteriorly with a little fibrocartilaginous disc here, and that creates the joint called the pubic symphysis. And we have some movement there. That's an amphiarthrotic joint. Okay, so this is taken from your textbook, and this basically goes through joints of the body, and you're going to be given some specific joints out of this table that you're responsible for. Okay, we're going to look a little more in detail about synovial joints. Okay, because this is our third type of structural joint, and these are going to be specific types of joints that have a joint cavity. So we're going to have a space between the two bones. So we've got space here. And that space is going to be filled with fluid. So inside it is going to be fluid, and we call that synovial fluid. Most joints in the body are synovial. Okay. Synovial joints tend to be freely movable, so they're going to be diarthrotic, right? So I always tell my students, when in doubt, synovial diarthrotic joints, because those are the most numerous in the body. And synovial joints are going to be the only joints with a joint cavity. They're the only ones that have that space in between. So some hallmarks of synovial joints, some structures that you need to be familiar with. Synovial joints have articular cartilage. And so this is basically hyaline cartilage that covers the epiphyses of the bones that create that joint and absorb compression forces that are traveling through that, through that joint. And they make it nice and smooth, and so they're going to reduce friction. And so what we see here is this, lining here, lining the ends of the bone are going to be articular cartilage, hyaline cartilage. We have joint cavity that is part of synovial joints. So that's going to be basically, the space between the two bones. You've got some space there. So that's going to be the joint cavity. We've got the articular capsule, or what we would call joint capsule. And this is 2 layers. The outermost layer is going to be the fibrous layer, and that's dense irregular connective tissue. And so that's going to be kind of an outer layer of, I'm not drawing too well on this picture here, but the fibrous layer of the articular capsule is going to be your dense irregular connective tissue. The inner layer is going to be the synovial membrane, and that's going to be right inside the inner layer of the articular capsule. And the synovial membrane is important because it is what makes synovial fluid, which fills up the cavity with synovial fluid. And that basically reduces friction within that joint space, and it lubricates those joint surfaces really nicely. Kind of like oil in your car. That's what I always tell patients. It's kind of like the oil that lubricates your car engine. The point of the articular capsule is we've got a dense irregular connective tissue layer, and we know that that's not stretchy, right? So it's going to provide some strengthening for the joint. In fact, if we look here, this is an image that we've seen before, but this is showing you it's actually been cut here. This is the edge of it, and this edge up here has been reflected. But this is showing you this is the capsule, the joint capsule of the shoulder. So it's really thick, and it covers the whole capsule, or it covers the whole joint, and it adds a lot of stability. The second role of this is because of this synovial membrane, we've got now production of synovial fluid, which is going to reduce friction within that joint. And so here's our synovial fluid. Again, that's filling the joint cavity, and its role is to reduce friction between the bones as they move across one another. Another highlight of synovial joints are ligaments. And so these are going to be connective tissue. This is going to be dense, regular connective tissue that connects bone to bone. And so we see here, here's our ligaments here, going from this bone up here, and it's going to travel across the joint, and it's going to attach to a bone that's distal to the joint. And so they're there to provide stability and to help strengthen the joint, because again, synovial joints are freely mobile, right? Freely mobile. So they need some help with maintaining stability sometimes. So they need that joint capsule, and they need those ligaments to help them out. This is showing you too, I know we've seen images like this before, but these are arthroscopic images of, I believe they're all knees. Nice, smooth, articular cartilage that we see. Here we see some breakdown of the cartilage getting down to bone. Here we see kind of the edge of the nice, smooth cartilage, and then here it's worn down to bone, and then here definitely, we've worn down to bone. So this is basically just showing you how we have that articular cartilage that covers the ends of bones, but over time and as people get older, that cartilage wears out. It's not as regenerative as bone is. Synovial fluid, we talked about that being secreted by the synovial membrane, and it's basically about the consistency of egg whites. So it's a substance that's filtered from the capillaries that are present in that synovial membrane. And we also have hyaluronic acid that is added to it, which basically holds on to water and creates this viscous fluid that fills our joint space. So it helps to lubricate our joint surfaces and reduces friction when we have bones moving across each other. And what happens is when you warm up, it becomes less viscous. So it basically becomes less thick, and it's able to coat those joint surfaces really nicely. And so this is why older people, if you talk to older people or maybe grandparents, they'll maybe complain of joint pain when they first wake up or when they first stand up after they've been sitting for a long period of time. But the more they move, that synovial fluid becomes less viscous, it kind of warms up, and it coats those joint surfaces really nicely. So then they notice, oh yeah, I feel a little better now, now that I've warmed up. So we always have our patients, when I've worked with older patients in the past, always have patients warm up first before they actually do any of the more difficult exercises. This is showing you there are synthetic synovial fluid injections, and one type on the market is called Synvisc. And so this is synthetic hyaluronic acid that you can inject right into the joint cavity, and basically it's basically synthetic synovial fluid, and it helps to coat those joint surfaces because as you get older, the amount of synovial fluid decreases. So you have decreased, protection against friction in those joints. So this is one treatment for that. This is also highlighting ligaments with synovial joints. So again, they're dense, regular connective tissue. They're going to attach, bone to bone. So here's a ligament here, here's one on this side, and they're going to help provide stability. So when we see people like this is a performer with Cirque du Soleil, and people say, oh, well, they're double jointed. That's how they can have flexibility like that. Well, is there such a thing as double jointed? No, there really isn't. What happens is that their connective tissue structures have increased flexibility, so they allow those joints to move through a greater range of motion. So they basically have increased range of motion, and it allows them to move in ways like this. Other people don't have that much flexibility in their connective tissue structures, and so there's no way that they would be able to do this. And then there's some synovial joints that contain other structures. For example, articular discs, or we call these menisci. And these are going to be small discs within the joints. We see this in the knee joint, and you also see this in the TMJ, the temporomandibular joint. The temporomandibular joint, so the joint that's formed between your jaw and your skull, both of these joints have menisci in them. And so what we see, like if this was our knee and this is that's not a great tibia, but there's our tibia, what you're going to see are these fibrocartilaginous cushions that basically sit on top of the bone. And what they do, so like here would be my menisci on this side, here's a meniscus on this side. It basically like improves the fit of the joint, because what you see with these guys is they'll be kind of like built up on the edges and kind of come down in the middle, because the end of the femur, when it comes down, it's shaped like that. It's kind of rounded on the bottom, and so it's a better fit with the meniscus. And it's also going to help to absorb compression through the knee joint itself. Okay, a few other structures. We have bursa that are located within synovial joints. And so these are basically little sacs of fluid. You can see here, this would be one of the bursa here, this little guy. These are little sacs of fluid. They actually contain synovial fluid, and you're going to see these in locations where structures might rub together. So like maybe where you have a joint underneath underneath a ligament, and every time you raise your arm up, it could rub there. Well, we're going to have this little sac of synovial fluid in that area that's going to reduce friction in areas where structures might rub together. And so if you had some pathology associated with this, you might have bursitis. You might have heard people have that. Bursitis would be an inflammation of that bursa sac. And then a tendon sheath would be a specific type of bursa. It's kind of long, and so it kind of wraps around a tendon, and you're also going to see it in areas of friction. So we see tendon sheaths in the shoulder, and we also see, I think, I don't have a picture of the hand, but in the hand, you also see tendon sheaths there as well. So like we talked about, synovial joint stability and mobility are inversely related. So what we see with synovial joints is we have increased mobility because these guys are freely mobile. They are diarthrotic joints. So what they do is they need some help. They need help with stability. Okay? Otherwise, they'd be popping out all over the place. So we have 3 different factors that play a role in increasing synovial joint stability. One of them is going to be the shape of the articular surfaces. So the surfaces of the joint, how is the joint formed? What's the shape of it? We've got ligaments that are present to span the joint to help create stability. And then we've got muscle tone, which is basically the tension of the muscles that cross that joint. And this is our most important factor. So this is where the importance has. Here is our most important factor in joint stability. It's going to be our muscle tone. Okay, so I'm just reminding you, here it is again, mobility and stability are inversely related. So the articular surfaces of synovial joints. So a lot of joints in the body are very shallow or non-complementarity. So, or non-complementary, which basically means that the joint surfaces don't always fit, perfectly together. And that's kind of like what the hip joint looks like. So if the joints are shallow or they don't fit together well, they're not really going to contribute to the stability of the joint. But some joints have really stable articulating surfaces, like the joint of the hip. It is very deep, the socket is, and it does create a lot of stability. For instance, if you compare this nice deep hip socket to the joint of the shoulder, the shoulder, it's kind of a flat surface, and then you've got the head of the humerus that's going to come up and kind of attach into it. Those would be non-complementary joint surfaces. These are very complementary. Ligaments of the synovial joint. So we do have the joint capsule, and we've got ligaments that are there to hold the bones together. They help prevent excessive movement and provide some stability. It's interesting to note that ligaments that stretch out stay stretched out. Ligaments are not, they're not able to generate tension. They are not contractile like muscle is. So ligaments are not contractile. So once you stretch them out, they're kind of like a rubber band. They're going to stay stretched out. And this is why people who sprain their ankles and stretch out the ligaments that support their ankles will repeatedly sprain the same ankle over and over again. Ligaments can only stretch to about 6% of its length before snapping. So ligaments, they provide a lot of stability, but they're kind of unforgiving. And this is showing you, here's all the ligaments of the shoulder joint. Look at all of this to help stabilize that super mobile shoulder joint. And then our third factor, and our most important one, is muscle tone. And we said that this was our most important stabilizer of synovial joints. And muscle tone is basically created by the tension of the muscle that spans the joint. And so the muscles are going to come down and they're going to attach through a tendon, which is going to be that dense regular connective tissue crossing the joint. And it's basically kept under tension by the muscle tone of the muscle that tendon is attached to. And so muscle tone is going to be the most important stabilizer of synovial joints. And I just wanted to show you a couple examples. If you've ever seen kids sit like this, we call this W sitting. And that's basically just because they're super flexible in their knees and hips when they're little. This is an example of hypotonia. So this is decreased muscle tone that you commonly would see in newborn babies. And then here's an example of a child with increased muscle tone. It's neurological in nature, but you've got increased muscle tone, so you've got increased tension of the muscles that cross that joint. Okay, the next thing is going to be movements at synovial joints. And so we can create movement across a joint by contracting the muscles that cross that joint. The skeletal muscles that attach to the bones are going to contract and they're going to create movement. And so we can talk about the muscles at their origin, and that's going to be the attachment at the less movable end, or the part of the bone or the joint that's not moving. The insertion is going to be the attachment of that muscle at the movable end. And so what happens is body movement occurs when the muscle contracts or when the muscle shortens, and it moves the insertion closer to the origin. So like in this case, this would be my insertion, this would be my origin, and I'm moving my insertion closer to my origin. You will also see this listed as the proximal attachment of the muscle. So origin would be proximal attachment. Insertion would be the distal attachment. So you're actually going to see this written both ways. So this would be your proximal attachment here at your origin. This would be your distal attachment at your insertion.